Assalamualaikum and good morning, everyone. Our next speaker for breakfast at UMHealth is Dr. Veenesh Selvaratnam, an arthroplasty surgeon at the Joint Reconstruction Unit, Department of Orthopedic Surgery, University Malaya. His last presentation at breakfast at UMHealth was 3 years ago with a talk on when the robots take over hip and knee replacements. Since then, we introduced daycare arthroplasty services in an effort to mitigate our long waiting list for hip and knee arthroplasties. So today, he will be sharing our experience with daycare and robotic hip and knee replacements. Please welcome Dr. Veenesh.
Thank you, Prof. Azlina, and good morning, everyone. So today I'm going to talk to you about daycare, same-day discharge, hip and knee replacements, as well as I'm going to recap on robotic arthroplasty. I think when we first gave our talk about 3 years ago, we were talking about robotics, but we have not brought in our service at that stage yet. We brought it in 2023, actually, and that's when we started our daycare services. Actually, our daycare services started even before our robotic services started. So I'm just going to, the outline of my talk today is I'm going to tell you what osteoarthritis is, what robotic arthroplasty surgery is. Arthroplasty essentially means joint replacement. What is daycare arthroplasty? And how do we apply this to our patients and how it can actually benefit our patients? So I did all my training in the UK, and this is where I learned robotic hip and knee replacement surgery, and also this is where I got experience in daycare same day discharges. So I spent about 18 years in the UK, and I worked in centers like Exeter. So these are big centers for arthroplasty, hip and knee arthroplasty, including Wrightington, which is Sir John Chanley's Institute. And fortunately, while I was there, when I was doing my fellowship in the Exeter Hip Unit, I was also selected for the first ever European EFORT robotic traveling fellowships. And I visited great centers in Germany, France, as well as in London with Professor Faris Haddad, who's one of the very experienced surgeons in the UK. So, before we go and talk about daycare arthroplasty or robotic arthroplasty, we need to know why are we doing this surgery. So, what is osteoarthritis? So, most of our cases that we do arthroplasty on or joint replacement on for hip and knee are due to a wear and tear of the hip joint or the knee joint. So these are chronic joint conditions, and it's characterized by cartilage degeneration, and it's a progressive disease. So since our population is getting older and older, patients are living longer, we see more and more of these cases. So on your left, you can see a normal looking knee and then a worn out knee. So you get bone on bone osteoarthritis. Essentially, it's just like how your tire gets worn out while you're using it. The more you use it, the more it gets worn out. And on your right, you can see a patient with hip osteoarthritis where there's loss of joint space and there's sclerosis. And patients with these conditions, they normally present with pain, swelling, and deformity. And if you have a look at the radiograph on your right side, the patient has got severe bowing. This is called varus deformity, which is the most common deformity for knee osteoarthritis. And the X-ray next to it shows that the patient had already had knee replacements, and you can see the legs or the alignment is much straighter compared to pre-operatively. And the implants used are different from a standard knee replacement on the right side. The right is a more constrained knee replacement. And so, what are the signs and symptoms? So, patients normally they come in because of pain. Some patients have pain and a bit of deformity as well. So, the leg is either knock knees or whether the patient has got a bowed knees. They complain of pain when they're walking. They can't sleep at night, and these are all signs and symptoms of osteoarthritis, either in the knee or the hip. And when we see these patients, the most common or basic investigations we do is a plain radiograph of either the hip or the knee. And the X-ray findings are obviously loss of joint space. So once the cartilage gets worn out, the bony parts become closer. They get osteophytes. They had subchondral sclerosis and subchondral cysts. And the grading is what we call the Kellgren-Lawrence grading, and the management or the treatment of hip or knee osteoarthritis depends on the patient's symptoms as well as the grading of their osteoarthritis. So, if the pain is not severe, if the grading of hip or knee osteoarthritis is not bad, you can treat them non-operatively, physio, rehab, a bit of physiotherapy, a bit of analgesia. You get them strengthening their muscles around their hip and knee. If they have more pain, you could try and give some simple analgesia and see how things go. And there's a role for injections as well. You can inject them either with steroids, hyaluronic acid, and now these people are starting to use PRP and other kinds of injections as well. Once they've reached end stage knee or hip osteoarthritis, so there's bone on bone contact, patients have a lot of pain, then you need to think of some kind of surgical intervention. In a younger patient, you can do an alignment kind of surgery. So you break the bones, you straighten it, and you try and distribute the forces around the knee to try and preserve the patient's own knee. Sometimes it becomes too bad, then you need to think of replacing it. And replacing again, for a knee, you can either do a partial joint replacement or full joint replacement. For the hips, if they've got osteoarthritis, the best management is actually a hip replacement if once they've exhausted all their non-operative interventions. So you can do a hip and knee surgery, but what is the current problem actually? When you think about it, a joint replacement surgery is essentially an alignment surgery involving the bone and soft tissue. So if you do a hip or a knee replacement, you want to try and get the alignment perfect. And we know that getting an alignment perfect and accuracy is key to longevity of the prosthesis and improve patient's function, because these knees or the hips, they don't last forever. If you look at registries these days, the survival rate of a hip and a knee replacement is around 93 to 95% at 20 years, which is not too bad. And these are hip and knee replacements done 20 years ago. And obviously now with technology, better implants, we're hoping that arthroplasty surgery or hip and knee replacements, they last longer. There's some papers that suggest patients who have a knee replacement, the dissatisfaction rate is up to 20%, which is quite a lot actually, but we don't normally see that these days. And why do we think the dissatisfaction rate is high? Patients, they've got higher expectations. Patients these days think that if you do a hip or a knee replacement, the joints are back to normal like what they were when they were 20 years of age, which is not really true. Some of them have got limited knee function, so they don't get full range of movement. And some patients still have got a bit of occasional pain. So how do we get rid of this, or how we think we can get rid of it? I think a lot of it is patient selection and how we actually counsel our patients and doing the right things for our patients. But some people argue and say that robotic surgery is the way forward to try and eliminate or try and improve function uh, for our patients. And what is the robotic technology? Essentially, it's a very sophisticated preoperative planning tool, and you can use these tools for to plan your surgery and to align your implants accurately. And it's a robotic arm assisted joint replacement surgery with computer navigation. These robots do not actually perform the surgery. I'm going to show you some videos as well later on and on how actually this robot actually works. The robot is just there to assist the surgery, assist the surgeon, but the surgeon is still doing the hip and knee replacement. And when you look at a lot of registries, so this is the Australian registries, more and more people are using some kind of technology to help or to aid their surgery. Conventional surgery is going down, and robotic surgery is going higher up, and this is the Australian registry. And we know that if you get the implants perfect, or you get the hip and the knee replacements or the alignment perfect, it actually improves patient's function, it decreases complications rate, and it optimizes durability. So every time you do a hip and a knee replacement, you want to try and get it perfect, and you want to try and hit the jackpot, and get the leg as straight as possible with good function. And how do we do it? We think that the robot is there to help us. And if you get a badly aligned hip or a knee replacement, with a knee, you can get accelerated wear. So the knee gets worn out. And if the knee gets worn out, you get component loosening. And all this will lead to revision surgery. So when you try and do an arthroplasty surgery, you want to try and make it last for as long as possible, and patients do not need to come back for a revision surgery. And if the alignment is not good, patients can get instability, you can get knee dislocations as well. But knee dislocations is not as common as hip dislocation. Patients can get pain and stiffness. And what about the hip itself? So there are many different robotic systems, actually, and currently the one we have got a ROSA, which actually is more for a knee replacement, but we're hoping to get one for the hip as well. And if you put a hip in a bad position, or you don't get the components right in the acetabular side, so in the socket, or on the femoral side, the femoral stem, you can get dislocation. So essentially the hip coming out of the joint, which is about 1% of all total hip replacements. You can get accelerated wear, component loosening, pain, and leg length discrepancy, which patients actually hate. So you want to try and do a hip replacement, you want to get the length perfect. There are ways of doing it. Try and get the length perfect conventionally as well, but the robot is there obviously to help you as well. And essentially, it's the same analogy as using a manual map. No one uses the manual map these days, and everyone uses Waze or Google Maps. And to do a traditional, traditionally, conventionally, you put the acetates up on a plain radiograph and try and guess the size and guess the bony cuts that you need to make. But with a robot, or planning a robot, you get a planning that looks something like this. It looks better. It helps you guide how much bone you need to cut, how much bone you need to resect, and also implant sizes as well. And as I said earlier on, the robot is there to help the surgeons for planning and for alignment, but the robot is not there to perform the surgery as such. So manually, when you compare it to robots, so the robots, it's said to give greater precision. You say less bony cuts and less soft tissue damage. And as I said, you get your alignments right, so you put your components in the right position. And some patients, or even some surgeons argue and say that when they have or when they do a robotic knee or hip replacements, patients get less pain post-operatively, and the hospital discharge is earlier and with a greater functional outcomes. But what we know is that actually what we tell the robot does what we tell the robot to do. So the robot is still controlled by the surgeons itself. And it also, with by doing robotic hip and knee surgery, we can try and reduce the equipments or the implants in theaters, as we have got our planning, so we don't need all the conventional jigs to be brought in. And this is how planning of a knee replacement looks like with one of the other systems. So the surgeons are able to size and align the implants visually before we even do the surgery. And with our robot that we have got, the ROSA, is actually image based. So you don't need a CT scan, you just need a plain radiograph. But and also, if you don't get a plain radiograph, you can still plan these surgeries intraoperatively. So a patient needs urgent a knee replacement, and sometimes when you do these X-rays to plan it, it takes about 5 to 7 working days. But with the system that we have got, you can do it imageless as well. So essentially, you take the patient to theater and you can plan the surgery with the robot during your surgery. Uh, so after you planned it, you put your planned. You can also do dynamic views, because surgery or knee replacements and hip replacements depends a lot on their soft tissue as well. So it's not only bones; it's the soft tissue as well. And some patients got very lax soft tissue. So while doing the surgery, so during your intraoperative planning, you just need to move the knee around to check for any laxity of the tissue or any tightness. So some parts of the knees is tight, the other parts is lax. So that the bony cuts will depend on that as well. And these are videos from theater as well. You can see the robotic arm, the ROSA robotic arm. So the surgeon is obviously still scrubbed and still doing the surgery, and the robot is just there essentially to plan it. As when you can see, there's a video there, there's a screen there that actually plans the surgery. And that is obviously me, and you can see the robot bringing in the cutting guide. So the robot places the cutting guide, and it tells you where exactly to cut according to the planning, pre-operative planning as well as intraoperative planning. And you can see here the surgeon is still doing the surgery. And same thing here, you can see the robot bringing the jig to the shin bone or to the tibia, and also the robot bringing the cutting jig to the femur. So when I do my knee replacements, I don't use a tourniquet, and you can see that's why it's slightly bloody intraoperatively. But I think patients do better post-operatively without a tourniquet. So intraoperatively, the slight a bit more bleeding compared to using a tourniquet. And so once you've made your bony cuts, you put your implants in, and again, you can trial your implants, and the robot will tell you whether the knee is well balanced or whether there's any laxity, and whether you need to do more soft tissue releases or whether you need to do more bony cuts. So as I said earlier on, this is our ROSA robotic system. So before surgery, at least a week before surgery, patients they have an X-ray, and then we get a preoperative planning, and then intraoperatively you have to do your planning as well, because sometimes the planning preoperatively changes intraoperatively, and then you do your surgical procedure. So fortunately for us in we got our robot without buying it, so it was loaned to us, but we still have got it. So when you look at it intraoperatively, the cost is slightly higher because you have to use some disposables, and but it's said to have a lower inpatient stay, and post-operatively patients will need less pain relief, and overall the cost is reduced. And so we were fortunate to get this on the 7th of August 2023, and this is when we did our first two cases. And this guy was an elderly gentleman, he's an 81-year-old gentleman. He actually had his previous left knee done elsewhere, and he stayed in hospital for about 5 days. And you can see this is him the next day post-operatively after his right total knee replacement using the robotic system, and he went home the next day itself. So the left one was done elsewhere 5 days, and when he stayed with us, he went home the next day. And similarly, this patient was a 82-year-old lady. She had a right knee replacement, and you can see she's walking quite well post-operatively day one, and her x-rays were fine. And this lady, she was about 4 weeks post knee replacement, and you can see she's walking quite well without any aids in our clinic. So I said earlier on we had our robot somewhere in August 2023. But before that, we already started our daycare same day discharge services in PPUM. So the first case we did was the 15th of March 2023, and essentially, when you compare inpatient arthroplasty and outpatient arthroplasty, and some papers suggest and some papers say that the inpatients actually have got more complication than outpatient arthroplasty, but I think maybe it's because the daycare patients are fitter, and they got less comorbidity, so they obviously do better, but they're going home in the same day. So what is exactly daycare knee arthroplasty? Essentially, patients come in the same day. So they come in the morning of surgery. So in our center, they come in all to the daycare about 7:30. So this is on the fourth floor of daycare theater. They arrive at 7:30. We start surgery about 9 o'clock. We complete surgery about 10:30, and about to 3 hours post about 2 to 3 o'clock in the afternoon. So that's about 6 hours post spinal. Patients have starting to walk, and they're discharged the same day about 4 to 5 o'clock. So obviously we got a very strict criteria of patient selection. So all these patients, they actually have a spinal anesthetic. They have an adductor canal block to help with their pain, and they get good pain medications as well. So this is our flow chart. So the most important thing is patient selection. We send them to anesthetic review to make sure they are fine. They don't have significant cardiovascular problems. They live nearby. They got good family support. So obviously, if there's any problems, they can come back urgently. But to be honest with you, we've been doing it for more than 3 years, and so far we have not had any readmissions when patients are discharged because our criteria is very strict. And this is our first patient. She's a 67-year-old lady, actually. So she had bilateral knee osteoarthritis. So when we first started off doing daycare knee replacement surgery, we didn't use the robot, and this was a conventional method. You can see she's walking about 4 hours after surgery, and she went home the same day. She liked it so much, she came back for her other knee 3 months post-operatively, again with a conventional method here. You can see she about 3 months prior to this, she came in for her left knee, and now for her right knee. And this is her about 4 weeks after her knee replacement. And I saw her about 3 years post-operatively, just after Thaipusam, and she said she walked up and down Batu Caves. And this is another guy who's in his 60s. You can see here, the whole procedure actually happens in our daycare unit, and you can see here he's walking about 3 to 4 hours after surgery. And this is another patient. You can see they can straight leg raise. So even though you do a standard medial parapatellar approach to cutting through the quadriceps tendon, they're still able to flex and extend their knee, and you can see the extensor mechanism here is intact. They're able to straight leg raise, and everything is in theater. So we had our robot in somewhere in August 2023. We started daycare in March 2023. So what we did is that we combined daycare robotic knee replacement surgery, and this was one of our first patients here. He had a robotic assisted knee replacement. And you look, this guy, the week after we did another case as well. You can see this guy is changed, and he's walking home actually after knee replacement surgery that he had done in the morning. You look at this lady; she's it's very impressive case. Look at her; she was here with her husband, and she's really walking about 3 to 4 hours after her knee replacement surgery. She looks very happy next to her husband here. And just after she was discharged from hospital about 4:30 in the evening, she walks to a food court and to have some food with her family members. And this is a very impressive video, actually. And how do they do after surgery? So this is her 1 day post-operatively. You can see her extensor mechanism is still intact. She's still able to straight leg raise her leg, and she's still able to bend her knee to about 90 degrees. And this is, we normally see our patients about 2 days. So our daycare is only on Wednesday mornings, and we always see our patients on Friday morning in our GRU clinic, just to make sure they're fine, and just to make sure their wound and dressing is fine as well. You can see she's perfectly fine walking. This is another lady. If you look at her, she has, both knees are quite bad, but we have done her left knee, and you can see she's bending in more than 90 degrees. She's able to fully straight leg raise, and essentially showing that her extensor mechanism is intact, and you can see she's at least bending it to about 100 degrees. And this is her at day 2 in clinic with a walking frame, and after about a week or so, she's just walking with one stick, actually, and you can see her straight leg raise is still intact. And we did knees, and now we're starting to do hips as well. So we did the first ever daycare hip replacement in the country, actually, on the 7th of May 2025. Actually, the hips are slightly more difficult, because in Malaysia, most of the deformities are quite bad. So we don't get simple hip osteoarthritis, and and therefore there are not many hip daycare cases, but we have successfully performed daycare same-day discharge hip replacement. This was a 72-year-old lady who lives nearby. So essentially, we got, as I said, we have got a very, very strict inclusion and exclusion criteria. So inclusion criteria are patients who are willing to participate, who live nearby, because our normal standard inpatient waiting list is quite long. So to try and get the better patients, or patients who do not have any significant comorbidities, to be done faster, we started this daycare same day discharge service. And exclusion criteria is patients who have got any cardiovascular problems, have got any who are not willing to cooperate, who do not have any family members at home to take them home, or patients who do not live around Klang Valley. We do not try and recruit them. And we've got an age limit of about 75 years old. So patients above 75, we do not include them in this daycare services. So I think we have really, I mean, there are lots of improvements, a lot of modern technology coming into arthroplasty surgery, and we are continuously trying to evolve. And to be honest with you, we have started a lot of services here, including our daycare, same-day discharge. The way we do it here is very, very different from other centers. So in our daycare same-day discharge, patients do not even come into the ward. They're they're coming to the daycare center, to our theater unit, and they have surgery there, and they're also discharged from there. So they do not come into the ward at all. So in conclusion, so I think whether robot or human, so I think with regards to whether robot is better than human, I think robot is just there to assist us, but it's not a bad technology, and it's a good thing. Thank you.
Hey, thank you, Dr. Veenesh, for updating everyone on the current services provided by the Joint Reconstruction Unit. We don't have a question except for a comment from Prof. YK Chan. She says, I notice in most of your patients, the sarong is too long and maybe a trip hazard. Please make sure the sarong is never below the ankle. And I think, yeah, it's the sarong that comes from the hospital. Sometimes, for those of us in the ward, we know that despite best efforts, the sarong just wants to slip down below. But yeah, Veenesh, next time change your videos to something with
Longer sarong.
long sarong. Or I like the one where you had the photo of the patients in the ward where you tie the sarong over their shoulder.
Yeah.
Some patients don't allow that also because for modesty purposes. I realize that, but yeah, certainly for to avoid falls under your watch. Good advice. Any other questions from the audience with regards to daycare, hip and knee arthroplasty with or without robot? Okay, I only note that in the Q&A box, there's also another comment by Prof. YK, and it's for our first speaker. She says she was offline while you answered live, and was wondering if you could answer the question again. I think I can do that for you. Correct me if I'm wrong. You're basically saying that you do not have any idea if there's a correlation between use of vitamin D and calcium with calcifications in the heart, because you're not privy to that information when the CT is booked. It would require some review of the patient's full blood work as well as the scan. So yeah, it's something that probably Prof. Chan, you have given them something to look at. And I'm sure they'll be able to answer you once they know if there is such a correlation. Other than that, I don't see any other questions in the chat. In the Q&A box. I don't see anything in our chat box. I think we are good for time. I wish everyone a very good day and a good rest of the week. Thank you, Dr. Veenesh. Thank you to all the speakers. And take care. Assalamualaikum.
Thank you. Thanks, Prof.